Good afternoon. My name is Laura Weil. I am one of the midwives here at Mission Bay at UCSF. We're coming together to talk about a topic that isn't widely discussed, early pregnancy loss and miscarriage. We're very fortunate to have a panel of experts here with us today. But since it's such a common topic, we really wanted to make sure that everyone had a chance to hear some of the facts about early pregnancy loss. Nearly half of women are going to experience an early pregnancy loss or a miscarriage at some point in their lives. And it often takes us by surprise. It's not something we've been prepared for in our high school sex ed classes. So we wanted to really talk frankly about what to expect and what it looks like. I want to first introduce you to Dr. Meckstroth, who's our director of the Women's Option Center here at UCSF and a clinical professor in the School of Medicine. Welcome, Dr. Meckstroth.
Thanks. Do you want to go to the slides? We often talk about pregnancy loss, which is the main terminology we use for miscarriage. And it really arbitrarily has been determined to call it that up to 20 weeks. After 20 weeks, even though it's still a loss of pregnancy, we tend to call it something different like stillbirth or fetal death. And then early pregnancy loss is usually in the first trimester, and first trimester goes to about 13 or 14 weeks, so it's usually up to about 13 weeks. You'll also hear, it means the same thing as miscarriage and spontaneous abortion and embryonic and fetal demise. And then when it happens really early before an embryo forms, it's often called anembryonic pregnancy. If we can have the next slide. It's old terminology. People will often hear kind of missed abortion as if something was missed when a pregnancy stops growing, but it doesn't pass on its own. But that's actually the norm, and it's really common that we see people with a pregnancy that we find out that it stopped just because there was spotting or that someone had a routine ultrasound. And of course, there's no failure involved as far as anyone's activities. It's not, so we'll talk more about that, but we try not to use that sad term as much. There's also old terms like blighted ovum, which really is very imprecise and doesn't tell us anything and sounds like a plant disease, so we don't use that. Threatened abortion, you might hear that. It just means bleeding in early pregnancy. Next slide. And as Laura mentioned, it's really common. Almost about half of women will experience at least one in their lifetime. In the next slide, you'll see that it's of clinically recognized pregnancies, so pregnancies that people go in and have a documentation of their pregnancy. It's about 15% in general. That goes up substantially in women who are closer to age 40 or so, and Heather's going to talk more about that. But this is it's way more common when we actually test, like if you test someone's blood or do very early pregnancy testing, we know that pregnancies that start and grow a little bit and then stop are actually much more common. Later losses, though, are less common. So loss after 13 weeks is only about 2 to 3%. So most people do feel more comfortable that the chance of that happening will be less. We said about half of women in general are people who can get pregnant, but about 43% of people who have one child have also had an early loss. And we don't always talk about it super easy, comfortably with each other. Heather's going to talk more about the things that increase pregnancy loss, but really there's very few times when we can identify something or there was anything that someone could have done to prevent it. And the next slide. One of the most common questions we get is, well, will this increase my risk in the future? And with only one prior early pregnancy loss, the two different colors are two different studies. So it will, I don't know if you can see my pointer, but the one early pregnancy loss on the left really ends up with about the same risk as with before someone has a pregnancy loss. And we'll talk more about most of the time people who have 2 or 3, it's actually still just a random loss, but there are sometimes issues that can cause recurrence. And the next slide.
So Dr. Meckstroth, do you feel that women can be reassured after one miscarriage that they will go on to have a successful pregnancy?
Yeah, by far the majority of people are reassured, can be reassured and know that they're, knowing that it doesn't make it easy to know that you're not in the population of people who experience infertility, since it was successful in the uterus. But it sometimes is a little comforting to know that the chance that you are able to get pregnant and that it will be more likely to be successful for most people is really the case. And then the next slide. And we really don't have much about prevention, because they're really, for primary preventing it from happening for the first time, there's so few things that can do that. Taking care of yourself for medical conditions, but really they have to be pretty far advanced to have a high risk of pregnancy loss, like diabetes or thyroid disease and things like that. We found that prenatal vitamins don't really reduce the risk, although a couple studies suggested that it might reduce the risk of stillbirth or possibly have a little bit of a benefit. And there's other benefits to taking folic acid early, so we do recommend that. A lot of people, especially with recurrent pregnancy loss, you might hear about taking progesterone early in pregnancy, and that has not been found to be helpful to prevent a first miscarriage. And it's possible and questionable, and Heather might talk about that a little bit. But there's also no data for, when someone has bleeding or if they've had it before, doing bed rest or avoiding intercourse or avoiding jogging or heavy lifting. Sometimes people feel better just being cautious, but we really don't have any evidence that those things are helpful, and we know that they are normal in early pregnancy.
I want to introduce Melissa Whippo, who is one of our licensed clinical social workers here. She sees a lot of our patients post early pregnancy loss and has a lot of information about how to move forward and how to recover. Melissa, welcome.
Thank you. Thanks so much, Laura, and thank you, Dr. Meckstroth. That was really helpful information, and it supports, I think, what so many women go through emotionally, is looking for answers. There so often isn't a data-based explanation or answer for the why. Why does miscarriage happen? And I think what I see a lot of is that women tend to blame themselves. What did I do that caused this? And so I bring that up straight away because that's one of the things that I focus on when I meet with women who have experienced any loss throughout the course of their pregnancy, but certainly an early pregnancy loss, which is the notion that when there isn't an explanation or data to point to as to the why, so many of us tend to blame ourselves because it's really hard for the mind to wrap itself around a concept that's not concrete. So when the mind has nowhere to go, the mind wants to go somewhere concrete. So we blame ourselves. If it was my mistake, I can blame myself, and that's a way that I can process this loss. So that's the first thing that I want to mention, that as tempting as it is, as a way to process the experience of loss, to blame ourselves, I really caution against that. That there are so many other ways that you can support yourself or obtain additional help as you move through your healing process. But something to really acknowledge is that you never have your first pregnancy again. So with the first pregnancy comes a lot of hopes and dreams. We have all these visions of the future, what we imagine for ourselves and for our family life. So another thing that I talk to women about as they're healing and recovering, not just physically, but emotionally from the early pregnancy loss is how do you take care of yourself moving forward? Because there are several layers to the loss. There's the physical loss of the developing baby and all the changing hormones and what you experience as you recover. But then there's the different layers of grief and loss, the loss of expectation, the loss of innocence, because any subsequent pregnancy after the miscarriage is probably going to have a good amount of anxiety associated with it. And I'll get to that in a moment, but I wanted to say a little bit more about the different layers of grief and loss Most people are familiar with the stages of grief from Elizabeth Kubler-Ross. A lot has been written about them. And I think what's important to remember, and so just a brief review, and in no particular order, and it's certainly not linear, but anger is a stage, depression, sadness is a stage, bargaining, this goes with the blame. If I had not, been exercising so vigorously, maybe I wouldn't have lost the pregnancy. Denial, right? I'm fine, everything's fine, I'm not gonna give myself permission to even feel any of this, and then acceptance. And you can have all of those emotional experiences at the same time. And so there's the actual loss of the baby, but another layer is the loss of the expectation for how you had imagined your life to be and how you had imagined your family. So I find that it's important to tend to those different layers of loss beyond the actual loss of the baby, really acknowledging and working with and getting support around the loss of expectation for what you had imagined for yourself. And then the other thing that I wanted to mention is about subsequent pregnancy. So when and the research that Dr. Meckstroth showed is really helpful. And it's even though I'm not a medical provider, I do reassure women, if you've had one loss, especially an early pregnancy loss, to be reassured from the data that it doesn't mean that you're at increased risk of having multiple losses, and to try to have some hope for that, and to acknowledge the very normal presence of additional anxiety in the subsequent pregnancy. It kind of goes with the layers of loss and grief. Now you've also had a loss of innocence. This is no longer your first pregnancy. One expression we use is the veil has been lifted. You know a little bit more about things that can go wrong. And so you might find yourself being what we call hypervigilant, right? I can't exercise. I can't eat certain things. I can't do this or that. But because the numbers and the data can be really helpful and reassuring in this way, I think it's really important to work with the anxiety as it arises. And one way that I offer that women do that is by using a mindfulness practice. And the mindfulness practice can be really helpful with the anxiety in the subsequent pregnancy, because we can really name it and feel it as it arises. Here it is, here's my anxiety, can I be with it? And kind of naming it and being with it rather than judging it or pushing it away or making it wrong can be really helpful, because it can give us a little bit of space from it. And the mindfulness practice also gives us information. If the anxiety that we feel in the subsequent pregnancy is not assuaged by the mindfulness practice, that's an indication that we need a higher level of intervention. So maybe individual psychotherapy, maybe a support group. So those are some of the ways that I encourage women to cope with the early pregnancy loss. And one last thing to mention is that any prior losses that we may have experienced in our lives may come up again as a result of this pregnancy loss. So if you have recently gone through the loss of a friend or a parent or a grandparent, the loss of this pregnancy may really bring up those prior losses for you. So it's important to really tend to all of these different layers of the loss from an emotional perspective. And when I say tend to it, usually asking for more help or more support, whatever that looks like. For some women, a support group feels really good. There's the Helping After Neonatal Death group that's online now. There are lots of different online support groups for miscarriage. Certainly individual therapy can be really helpful. And finding a therapist who is experienced and familiar with particularly pregnancy loss is helpful. I find that unfortunately what happens, even with good psychotherapists, well-meaning people, they might say things that are really hurtful. Like, oh, the loss happened so early, you hardly had time to get attached to this baby, which is a terrible thing to say, because that might be true for an individual woman, but going back to the notion that there are several layers to the loss. It's also the loss of expectation about the future, or the life that you had planned for yourself. It's not really helpful to have anybody minimize the loss. Loss is loss in my clinical perspective. So it's not really worth comparing. It's worth addressing and dealing with the emotional layers that arise. So individual therapy can be really helpful for that. And for some women, the loss can be experienced as a trauma. And it depends, if the loss happens organically, if there has to be a medical procedure. Some women feel more or less sensitive to different medical procedures as they relate to the loss, or even the experience of having a loss at home can be traumatic. So to be on the lookout for symptoms of trauma as you're recovering and healing from the loss, because post-traumatic stress is an anxiety disorder. So it kind of goes with the idea that you may have some anxiety in any subsequent pregnancies. And part of that may be related to the trauma that you may have experienced during the loss, which, I hear myself saying all this and it sounds very bleak. I really believe that healing is possible. Healing doesn't mean that you forget about this experience or you have this experience minimized in any way. Healing is about integration. How do I integrate this experience of loss into my experience of fertility overall, which I'm sure Dr. Huddleston will address. As I move forward and I do my family planning, how do I hold the memory of this experience in a way that it's not constantly intruding upon me and intruding on my possibility to also hold hope? How do I work with the integration? How do I have this be part of my history and my story without having to re-experience the trauma of it? So therapy can be really helpful for that. So those are kind of the main ways that I find helpful in supporting women and partners too. The partner might experience an early pregnancy loss very differently than the non-gestational parent is not experiencing the early pregnancy symptoms the way that the pregnant woman is. So the experience of coping with loss can be really different. And I find it to be helpful to really encourage partners to have clear communication about needs and to try not to compare experiences, that we all navigate loss really differently and there's no right or wrong way to recover.
Lisa, how do you recommend interacting with friends and family? Do you tell them about the loss? Do you keep it private? Is it something that you encourage reaching out?
It's such a good question, Laura, and it's such a personal decision because some people choose not to share news of the pregnancy until they get past a certain gestational age. And I also find it's really challenging if you keep it to yourself, there's less opportunity to allow your community and your family to support you. So if people feel, some people are very private and they don't want other people to know about their emotional experience. That has to be respected. And if people feel comfortable sharing, I find that most folks don't know necessarily what to say to be supportive, and it's okay for people to say, I don't know how to support you, and I'm really sorry for your loss, and that acknowledgement can be helpful in the healing and recovery process. So I do encourage people, if they feel comfortable, to share the news, especially if you started out your pregnancy. I mean, most people are working from home right now, but if you are in a work environment where people knew that you were pregnant and then suddenly you're not pregnant, that can be really challenging to deal with. So sometimes I encourage people to designate one person that's close to them to be their information sharer so that they don't have to constantly be retelling the story. So at work, that might be a human resources person or a trusted friend. Hey, can you let people know? I don't want people asking me about it. I really encourage women to be as specific as they can with their needs and desires for support as they work through the loss. But I think whether or not to share is such a personal decision. I find it can be helpful, if someone isn't super private and they feel comfortable sharing. I think it when you don't share it with anybody, it puts the burden on you, on the individual, to hold all of that on your own, and it can feel limiting.
Yeah, it is an experience that so many women have. I think once you start sharing, you'll be surprised at how many of your friends and family and colleagues have similar stories to tell.
Exactly.
Interesting. Yeah. And then I'm glad you mentioned partners. I feel like that is a neglected area. I do feel like it's a sense of loss for them as well. Quite often they don't reach out looking for resources.
No, and it's sometimes the early pregnancy loss feels very abstract for the non-gestational partner, right? Because they're not experiencing it in their body, so they don't know how to show up for their partner, for the woman who is experiencing the loss. And there might be a way, I really encourage women who are experiencing the loss to be really communicative with their partner. I don't need you to fix anything or solve anything necessarily, but I would like XYZ. I would like to be held. I would like you to check in with me. I would like you to, make meals for me. And if the non-gestational parent partner is also struggling, for them to really be vocal about it as well, and to have the communication piece is so important for both people to say, without judging the other person for their process, this is what's happening in me, this is what's alive and arising within me emotionally, even if it's, I'm not feeling sad about it, I'm feeling okay about it. That for there to be space for all experiences to be welcome, to be okay.
Thank you so much.
Thank you.
I want to now introduce Dr. Heather Huddleston, who is the director of our PCOS clinic here at UCSF. She is a specialist in recurrent pregnancy loss. We're very lucky to have her here today. Welcome, Dr. Huddleston.
Thank you. Thanks for the two first speakers. Did such a great job introducing a lot of the really important issues. I'm going to talk right now about causes of pregnancy loss, which I like to really work with my patients to understand. And a lot of it actually aligns with what Melissa said, because I think as for many women, as they understand sort of the actual biology of what's going on, sometimes that can actually help avoid some of that self-blame that I think can be so incredibly common with the patients I see who've suffered a pregnancy loss. Next slide. So I'm going to start right off by saying, in terms of pregnancy loss, the majority of pregnancy losses occur due to a problem in the embryo. So this is the significant majority of pregnancy losses. The most common problem, when we talk about a problem in the embryo, the most common type of problem is that the embryo itself has an abnormal number of chromosomes. So this is just a fact of human physiology, a fact of human biology, that as humans, we create a lot of embryos that have an abnormal number of chromosomes and are therefore not viable. When we talk about an abnormal number of chromosomes, the other term for that is aneuploidy. So sometimes you'll hear people talk about aneuploidy. That means an embryo or a fetus that has an abnormal number of chromosomes. Next slide. So here's a karyotype. So that's when we look at chromosomes in a special way under a microscope. And this is an example of a karyotype of someone who had trisomy 15 for a pregnancy loss. So that's an extra chromosome 15. And you can see right there for all of our chromosomes, so the 23 set chromosomes we have, we expect there to be a pair, one from the mom and one from the dad. This test showed that this embryo had 3 chromosome 15s, and for that reason it was not viable. This type of problem, this trisomy or an abnormal number, can occur with any of the chromosomes. There's certain that are more common than others. Next slide. So aneuploidy, or an abnormal number of chromosomes, as I said, is the most common cause of a pregnancy loss for any age. but it is something that we do see increase in its prevalence as women get older. So again, happening at every age, but as you can see in this slide, the blue line is showing how aneuploidy really starts to increase as we age, and as at the same time rates of miscarriage really increase at that same time, and then live birth rates start to go down. So although this happens to everybody, age can be a factor, and that's just because as women age, our eggs don't do a very good job dividing up chromosomes the way it should, and we end up creating these embryos that have an abnormal number. It doesn't mean it will happen the next time, but it's just something that can happen more frequently as we get older. Next slide. So here's a slide looking at a study where they looked at both people having a sporadic loss, or meaning like a single loss, a random loss, and then looking at women who had a history of recurrent pregnancy loss, and looking at what was the chance that the tissue from that pregnancy was aneuploid or had an abnormal number of chromosomes. And you can see that for one, it goes up as we get older, and also that it is, in most cases, at least close to 50% or over 50%. And that even women who are having recurrent pregnancy loss, it's often the case that this is just something that's happening because of these chromosome errors. Next slide. So now that I've gotten that out of the way, and I like to start with that because it is really, if you're going to come away from this with anything, it's that I want you to understand the very common genetic causes of miscarriage. But what are some other non-genetic causes of miscarriage? Next slide. So this slide just talks about a few maternal conditions. So these are not things that are well understood. And as Dr. Meckstroth said, for the most part, things like maternal diabetes or other medical illnesses usually only cause pregnancy loss when they are very significant or out of control or not well controlled. Infection does appear to cause pregnancy loss, but much more common with later pregnancy losses, and its role in early pregnancy loss seems to be very minimal. Things like being chronically stressed or over underweight may play some very small role, but again, I would like to say that a lot of women will say maybe it's because I'm stressed that I had this pregnancy loss, and really there's not significant data that would point to that being a cause. Next slide. In terms of substances, again, this is an area where there's really not a lot of strong evidence, but we do know that a significant history of smoking and alcohol use are something that we would want to ask a woman about and likely recommend decreasing, because that may play a role, as well as other contaminants that could be in the environment. Listeria is an infection that can come from food, and that, again, much more likely to lead to miscarriages later in pregnancy. Next slide. So what are some causes of recurrent pregnancy loss? So this is a clinical problem that I see a lot of patients with. Next slide. Recurrent pregnancy loss refers to women who, a situation where we've had 2 or 3 losses. This is a study that was done looking at about 1,000 women that presented to a clinic with a history of recurrent pregnancy loss. And the authors of this study tried to break it down and see what were some of the things that were identified in this population. So first, I just want to point out that, again, about half of the population here likely had what they either said was unexplained or very likely a genetic cause. And again, getting back to that abnormal number of chromosomes. But they did find women that were not having that as the cause of their pregnancy loss. And they broke down some of the other things. So I'm going to go through each of these big categories right now. Next slide. So one of the smaller causes is something called a parental translocation. So this was, in this particular study, about 4% of the population had this. This means that either the mom or the dad carried or a mom or the other partners who provided the sperm, so it could have been the dad or sperm donor, had a translocation. So what that means is that there is a breakage of some of the genetic material within the chromosomes, and that can be fine for the person who carries it, but when they go to divide up the eggs, genetic material for eggs or sperm, you can end up with an abnormal number or an abnormal amount of genetic material. So this is a very real cause of pregnancy loss, even though it is rare. It is something that can be diagnosed by doing a test called a karyotype of the blood of either partner, so the provider of the sperm or that provider of the eggs can be tested for either of these things, for this cause. And if it is found, there's a variety of strategies for moving forward and ultimately having a healthy child. Next slide. Okay, next cause is anatomic. So this is always a very important thing that I like to look at because it is something that I certainly uncover in my patients. And so this means there's something about, generally something about the uterus that is making the patient more vulnerable to pregnancy losses. The big categories I've listed here, but a septum in the uterus, which means it's a sort of like a something that divides the uterus into two, or even a significant heart shape of the uterus. Fibroids, which are overgrowth of muscle in the uterus. Polyps, which is an overgrowth of the lining, or scar tissue. These are all things that we can look for, and if identified, can often be addressed and fixed to give the person a much better chance with a subsequent attempt at pregnancy. Next slide. The way that we can look for these types of things, there's a variety of different tests. An HSG is a test where we use dye in the uterus and take an x-ray. A saline sonogram is a type of ultrasound, or hysteroscopy is where we use a camera in the uterus. So these are all things that a physician who's doing this type of evaluation can use to determine if there's anything to be worried about here. Next slide. All right, next cause is something called antiphospholipid antibody syndrome. So this explains about 15% of patients with recurrent pregnancy loss. It is something where there's antibodies that the female patient will carry, and that these antibodies, which can be just sort of autoantibodies that someone might develop over time, can interfere with how the placenta functions. And so it is a syndrome which can cause clotting problems, and it can also cause pregnancy complications. Next slide. And just advance the text if you could, Matthew. Thank you. So nice thing with this syndrome is it's something that we can test for. So it is a standard test that we do when someone has had several miscarriages. And these tests are blood tests that the physician can order and help with interpreting. Next piece of text. And then the other little trick with this one is just that because these antibody tests can sometimes be sort of transiently elevated for reasons other than the true syndrome, we do recommend that this testing be done twice, 12 weeks apart. Next slide. And then endocrine causes. So this is sort of a hormonal causes. Next slide. So really the big categories here that I tend to look for are over underactive thyroid and then uncontrolled diabetes. So again, these are not sort of mild diabetes, but when someone really has out of control diabetes or out of control or very overactive underactive thyroid, would we think that that might be a potential factor of recurrent pregnancy loss? Next slide. So evaluation, I'm just going to touch on this, but I think the good news for patients to know is that if you are having several miscarriages in a row, that there often is stuff that we can learn and things that we can do, and also that there is a very good prognosis with this particular clinical problem, even though it often doesn't feel that way when you're in the middle of it. The basics in terms of the evaluation would be just a careful history by a clinician. Karyotype of the products of conception can be useful if you're having a pregnancy loss, because it can help guide us on whether or not this is a problem in the embryo or if it's not. And then, as I said, a karyotype, a genetic test of the mom or paternal source serum can help us understand if there's a translocation. a uterine cavity evaluation, testing for antiphospholipid antibody syndrome, and then some hormonal tests. So that's really the real basic, concrete go-to evaluation that I do when I'm addressing this clinical problem.
Dr. Huddleston, do you feel that patients need to come to a specialist right away after a miscarriage? At what point do you want to see them, and at what point can their primary care provider do some of this workup for them?
Yeah, I mean, I think it can really vary. Certainly when someone's had 2 or 3 losses, certainly that's a time where the patient themselves is probably really starting to feel stressed and wanting to get more information. So I think that if a primary GYN, primary care physician feels very comfortable with this clinical situation and is able to help obtain some of this testing, then that can be 100% fine. Certainly there are specialists out there who also do this type of work. So I think I would counsel the patient to sort of ask their provider, are you comfortable helping me with this type of workup and evaluation? And then if the provider is out of their comfort zone, that patient could certainly request a referral to someone who may be more comfortable. So I think the next slide is going to be bringing us back to Dr. Meckstroth.
Yeah, that's really helpful, Heather. Dr. Huddleston, when I see someone who's had multiple losses, we always talk about that last question about where and how much and how much evaluation they are interested in considering and where they'd like to do that. The next slide. So we're going to go back to just how do we know for sure that a pregnancy is non-viable, that it's not coming, not going to continue, and that it is a pregnancy loss? Because often bleeding in early pregnancy is one of the most common symptoms, but it's also something that happens in many normal pregnancies. Like 20 to 40% of early pregnancy have a little bit of bleeding at some times. One thing I hear a lot is, I knew that this was miscarriage because I didn't have nausea and I've had it with a prior pregnancy. And that's not true for everyone. Some people don't have nausea with any pregnancies. Some have them even with miscarriage. But there have been studies that suggest that bleeding with nausea maybe had a little better prognosis than someone who has early bleeding but has no nausea or had their nausea resolve. We also are really cautious of evaluating bleeding in an early pregnancy because there's sometimes other causes. An ectopic pregnancy or a pregnancy outside of the uterus is one of the most common concerns. It's still only 1 to 2% of pregnancies, and that's also a non-viable pregnancy, one that could never go on to a normal baby. But then there also could be something on the cervix or a rare genetic cause called molar pregnancy, or sometimes the bleeding, it's hard to tell sometimes where it comes from. Next slide. One of the most common is what we call kind of implantation bleeding. So right about the time when someone might miss their period and the pregnancy implants in the uterine lining after floating around for about a week inside the uterus and tube, that can sometimes lead to light bleeding. And sometimes people think that's their period, and that's one thing that can also lead to dating issues. Next slide. But most commonly, we diagnose miscarriage by ultrasound, and that is often started as an abdominal ultrasound, but usually for final diagnosis, especially with early miscarriage, a vaginal ultrasound is part of that evaluation. And there are kind of 3 main criteria that we use if the only information we have is that ultrasound. So if the only information we have, if we see an embryo that's bigger, that's at least 7 millimeters in size, and there's no early pulse or what we call cardiac or heart motion, even though the heart is still forming at that time, or if the sac around the pregnancy that has fluid in it, if that has grown to a considerable size, more than 2.5 centimeters, and then we don't see an embryo inside, More commonly, we don't quite meet either of those, so we're looking at lack of growth. So we want at least 11, sometimes 14 days between those two ultrasounds to be absolutely sure, so that there's no chance that we're wrong in the diagnosis. But interestingly, these guidelines from radiology from 2013 are still exactly what everyone uses, but they are very conservative, and they also don't consider patients' wishes in them. So next slide. The American College of OBGYN really makes it clear to reproductive health clinicians that we also have to really think about a patient's desires and whether they really want to delay intervention to achieve 100% certainty of pregnancy loss, or if they, sometimes people find out they have pregnancy loss and they weren't sure that they wanted to be pregnant at that time, and then that's enough to make them decide to go ahead with intervention. There's also the chance of having to go to the emergency room or having unscheduled bleeding and anxiety. But one thing that's really reassuring is that when we do see early bleeding or see some kind of concern, and then it goes on to be a normal pregnancy, we don't really have concern that that will cause problems later in pregnancy. So sometimes I'll hear, oh, but if you know it might be abnormal, I just don't want to take that chance later. But these kind of abnormalities that we see very early, if they resolve and there's no issues, they very rarely connect with any problems later in pregnancy. Next slide. So there's also other ways we sometimes can know that a pregnancy is almost certainly non-viable or certainly non-viable. One is what we call kind of minimum menstrual age, when someone says, I only had intercourse once, or it's obviously an IVF pregnancy, or they had a urine pregnancy test right at 4 weeks of pregnancy. So we can go by them having this information as part of the other information that we have with how long sperm can live in the body before conception, and kind of a little bit of error we know that can happen with ultrasound. There's also, we'll talk a little bit more about HCG, or the hormone of pregnancy. Many people who get a diagnosis of miscarriage have had their hormone levels followed. And that is something on the next slide, but don't change just yet. The only other thing I wanted to mention is that sometimes, rarely, luckily, people can have very heavy bleeding where they need intervention, or they could have a healthcare risk, a risk to their health from the level of bleeding from a miscarriage. And this can even happen when there's still heart motion in a pregnancy. That is something where we know the pregnancy won't continue, but if someone was to present to a religious care facility, sometimes that can be an issue for intervention for maternal health. So the next slide. So the HCG, the pregnancy hormone, there's really no absolutely accepted levels or diagnostic criteria or drops that we know for sure that will tell us that a pregnancy, how far along it should be, or whether it's a miscarriage just by hormone level. And that's because, as you can see in that graph, there's a huge variation in normal hormone levels. There's also a natural drop. So sometime between 8 and 11 weeks, you actually start to see leveling off of the hormone levels, and it stops rising. So we don't keep following hormone levels usually after we can see an embryo by ultrasound. But we do often follow the rise earlier than that, and there's several different criteria. Sometimes we vary it based on how the actual level of the hormone, but in general, about a 35% rise in 2 days. If that doesn't happen, the chance of a normal continuing pregnancy is less than 0.1%, so 99.9% chance it's not going to continue. And I also mentioned kind of like at what level of hormone we start to see different structures on an ultrasound, and that helps us with diagnosis sometimes. Next slide. So, Laura, did you have any questions about diagnosis before we move on to management?
I just wanted to get the takeaway there that bleeding in early pregnancy really doesn't mean that this is going to be an early pregnancy loss. And I think that can be very reassuring for women that bleeding is actually very common.
It is very common. I mean, it does increase the risk a bit, but it happens very often. And when it happens and goes away and the pregnancy continues, it is not associated with later problems. Yeah. Okay. The next slide for management. So there are generally 3 options that pregnant people can choose for management of an early pregnancy loss. And by early, we mean definitely less than 12 weeks, but sometimes we have other limits as well. One is expectant, and sometimes people call that do nothing, but I don't like to think of it that way because we really want to make sure people have good counseling, medicine to keep them comfortable when they pass the pregnancy at home, and all the information they need. Medical management, which is generally done with 2 medications that people take and then pass the pregnancy at home. Or aspiration, either in an office or in the operating room or in the emergency department. That's also often called surgical management, even though there's no real surgery involved, there's no cutting or anything like that. Or DNC, or dilation and curettage. It's usually suction curettage, but you'll hear those terms as well. And what we know is that people, when given these options, people often have really strong preferences, that when they hear the differences between them, they really have a strong preference between one or the other, and that we know that when we offer and support people to choose their different management option, that they are happier and that they have higher satisfaction with their care. Next slide. And things that might affect someone's decision between what route to go, and this has actually been studied nicely, and there's a lot of, there's even a questionnaire that we can provide people, but this covers most of those questions. Sometimes people value some of these issues more than others, like privacy, or if they could have treatment, sometimes by someone they know. If they've had a miscarriage or an abortion before, they might have had an experience that makes them feel like they want the same or want different. They might have had a friend or family who've had the experience. Sometimes they just want to feel like it's natural, and whatever that definition feels like for them. They may not want to see pregnancy tissue, or they might actually want to see pregnancy tissue. And next slide. And then there's also some physical factors, like people want to either avoid pain as much as possible, or avoid pain associated with, a procedure. It's possible that they don't mind pain at home, but they wouldn't like pain in an office. Sometimes the shortest time to get a resolution and move on, or spending less time, especially now in COVID, in a clinic or a hospital. Wanting to experience the experience at home with people that they know or who can support them better. I will say at UCSF, we do have visitors specifically for miscarriage treatment in most areas. So that is something that we do have an exception for during COVID. Lowest cost, sometimes it can be a dramatic difference depending on your insurance for that. Wanting to know that you're finished, and the chance that you'd need additional care to be as low as possible. Wanting to be asleep, wanting to not be asleep. Next slide. One thing that I feel like we can say from a lot of evidence, though, is that for most people, when we can offer all 3 options, they are all generally very safe. There's studies that compare them and find no difference in heavy bleeding or blood transfusion. Infection is luckily very rare, even when there's some considerable amount of time of waiting. Future live birth rates, so people who want to be pregnant again, it does not affect that. And also the people between medication management and aspiration, so the suction procedure, there's no difference in people who would either recommend what they chose for other people or choose it again. We do know that people who do medication management, the side effects can be different. Nausea, vomiting, diarrhea, and sometimes stronger pain are kind of the trade-offs of being able to pass the pregnancy at a specified time and earlier and avoid aspiration. Next slide. So this is kind of a long slide of all the different options, although I've split at the bottom that aspiration or suction procedure in an office versus in a place where anesthesia is definitely available. So expectant management is often people feel like that, they want to avoid the extra side effects. It feels more natural, it feels like they can just stay with their same clinician. And one of the most common reasons is they'd like to avoid anesthesia or surgery, even though, quote, surgery, even though that's very safe. The thing is about 20 to 40 of people end up needing an aspiration when they decide on the choosing expectant management. So to avoid that, some people will choose the medication management, taking the 2 medications, which we'll talk about in a second. And then they have about an 84% chance, so close to 90% chance of passing the pregnancy at a time, like within that week. And if the bleeding is already starting or you're starting to pass the pregnancy, this is even higher chance of being successful. This is plannable, and the chance you'd need intervention later or need a suction procedure is much lower than expectant management. It's also something that can be done in a regular office, so depending on insurance, that could be important to people. Aspiration in an office is often, we can schedule right away. It makes the chance that you'll need future treatment is only a few percent, so that it's like the fastest resolution for many people. It's often a 1-minute procedure, well, a 10-minute procedure, but we'll talk about what part is 1 minute. And then compared to the operating room, you don't have to not eat often. You can have continuity of care sometimes, and cost savings or time savings for people. But some people really want to be asleep, and that is an option in the operating room. Next slide. So expectant management, you have to watch for quite some time. And what we don't know to get a fairly high percentage of people passing the pregnancy completely. This also seems to be a little less, work a little less well when the pregnancy is very early before the embryo forms. So for most embryonic demises or pregnancy loss where we identify it in the uterus, it's about 75%. But if you're already passing, it's more. How long to wait is not defined. So some people think about it as 1 week wait. Some people really want to wait, up to a month. Once the pregnancy has remained in the body for a number of weeks, maybe 6, we don't know for sure, or 8, without passing on its own, then we start to think, be moved more toward the side of recommending intervention. And as I mentioned, then we talk about side effect management and medications that can be used, ibuprofen and Tylenol together, even though ibuprofen is really one of the best for pain control. Using it with Tylenol can be helpful. Some people do also want to take a narcotic tablet or 2. Next slide. And then medication management, we would go over this in great detail with people who choose it, but there's one medication you take by mouth and another that you take the next day or so by placing tablets in the vagina. And this has a much higher chance, almost 90%, of passing the pregnancy without needing an aspiration. Next slide. So the aspiration involves taking medication, sometimes relaxing medication as well, or even in the IV. And then sometimes we use a half dose of one of the medications that we use for home management, just to open the cervix a little bit more, but usually just a few millimeters of dilation with a metal dilator and then gentle suction. And the suction part sometimes lasts about 30 seconds. Sometimes it's, maybe up to 5 minutes, but it's a lot of time to make sure someone's comfortable with numbing medicine and preparation. Next slide. We do recommend intervention for people who have a negative blood type if they're 8 weeks or more. That's just to prevent problems in future pregnancy. And if we know that, we usually do it even earlier than 8 weeks, although sometimes that's not necessary for a very early embryo. Next slide.
Dr. Meckstroth?
Yeah.
Do you have recommendations for patients who are interested in getting pregnant again as quickly as possible? Do you have a management preference for those patients?
I do. I think it's our last slide. So I think we are just 1 or 2 slides from that. So just a combination, the last couple slides about when we know miscarriage is complete. Usually this is by symptoms. Once we know that a pregnancy has stopped growing, we can often just go by symptoms, but sometimes we will do an ultrasound. One thing that is really challenging is that ultrasound sometimes causes more problem than benefit, because you'll sometimes see on the right side, the uterus will see kind of a thick lining of the uterus because there's still some uterine lining left to come out. And even though that might mean it's incomplete at that moment, it doesn't mean that those people are going to need intervention. And most of the time it resolves very on its own without intervention, even when that thickness is up to 3 centimeters. That might be different though if it's been weeks since someone's passed a pregnancy, and that's something that we spend a lot of time looking at carefully. Next slide. And then there's your question, Laura, about for after early pregnancy loss, one of the most common questions is how soon can we try again? Earlier studies picked 3 months as this random comparison group where they would recommend waiting 3 months before you get pregnant versus no wait. And they suggested there could be a little higher chance of miscarriage, although several more recent studies have not found this. And studies that suggested or that looked at 6-month wait found that there was nothing but harm. So we really don't feel like the evidence is strong enough to suggest that people wait longer than they want to try again. That might be different if you've had 2 miscarriages in a row or 3 miscarriages total and are considering doing some evaluation. But light or moderate bleeding, it's not exactly like a normal period. Most people bleed a little bit longer and a little more irregularly than their normal period. And then the one thing I wanted to say is that the pregnancy test, even though it drops a lot, the hormone level drops a lot in the first few days, has a very long, slow tail of a little bit, so that the urine pregnancy tests, which are very sensitive, are still positive for 3 or 4 weeks after passing a pregnancy. And thank you, Melissa, for the really great overview of emotional support, because emotions are a really important part of our health, and we really hope that people get the support that they need. I think that's the end of my slides.
Thank you so much, Dr. Meckstroth. We don't have any questions. If you have any questions, please go ahead and put them in the chat. We can answer them now. But we will have a frequently asked questions paper on the website when you have the recording of this, if you wanted to go back and look at it again. There are some national resources. SF HAND, H-A-N-D, is a resource for patients who do live in San Francisco that has some support groups. And then nationalshare.org is another organization that deals with pregnancy loss and can offer some support. What I always will tell my patients is that there is a big difference between grief and grieving this pregnancy and fear that you will never have a baby. Those are 2 very separate things. And the reality is most women who do experience pregnancy loss will go on to have a baby. And so the fear, we don't want you to go there quite yet after an early pregnancy loss. But the grief is very real and can be explored. So please do reach out if you need help. We do have resources here. Melissa is available. We have other licensed clinical social workers as well, and then the national organizations on miscarriage. Thank you so much, everyone, for participating. Really appreciate your time.